Hi everyone, Dr. Minasri here. This is the second part of our presentation on pulmonary ultrasound. In ICU, we will build on the basics we discussed in the first video. We will now focus on how to interpret common pathologies that greatly benefit from ultrasound, such as pneumothorax, pneumonia, atelectasis, and pleural effusions. We'll conclude with a clinical decision algorithm. To begin, let's briefly review the two key elements of a healthy lung we discussed previously: A-lines and pleural sliding. Mastery of these normal findings is essential as they will enable us to confidently identify pathological conditions. Let's begin with the most urgent condition, pneumothorax. This diagnosis is based on a triad of findings: absence of pleural sliding. When absent pleural sliding, it indicates loss of normal lung movement. Absence of B-lines. The absence of B-line or comet tail artifacts is another key indicator. This absence suggests air in the pleural space, as the presence of air prevents the visualization of vertical artifacts. Lung point. The lung point is pathognomonic and represents the precise interface where the lung detaches from the chest wall, which confirms pneumothorax. In addition to these findings, M mode can provide dynamic confirmation. In the normal lung, M mode shows the seashore sign, where the lower part of the screen shows granular motion, like sand representing lung motion. The upper part remains static, horizontal line representing the chest wall. In pneumothorax, the M mode will reveal barcode sign horizontal lines with no vertical motion, confirming the absence of lung movement. The differential diagnosis that can also cause a lack of pleural sliding, selective intubation. Pleuritic adhesions also have apnea or unilateral ventilation, and large emphysematous bullae. Now let's address cardiogenic pulmonary edema versus ARDS. B-lines. Pathological B-lines act as true beacon light that widen toward the bottom. Their presence becomes significant with more than 3 per field. Confluence forms white line or B-line storm. A crucial rule here: bilateral and diffuse B-lines are always pathological. They are found in cardiogenic edema, bilateral pneumonia, ARDS, and interstitial lung disease. Conversely, focal B-lines suggest localized pneumonia, regional atelectasis, or pulmonary infractions. In cardiogenic edema, we see diffuse homogeneous B-lines, frequent bilateral pleural effusion, and left ventricular dysfunction on echocardiography. In ARDS, B-lines are inhomogeneous with consolidation. Characteristic pleural sparing appears with healthy zones adjacent to pathological areas. Pleural line abnormalities show thickening and irregularities. LV function is often initially preserved. For quantification, we use the LUS score, lung ultrasound score, very useful for monitoring. 0 shows A lines, normal lung. 1 shows separated B lines, moderate impairment. 2 shows confluent B lines, severe impairment. 3 shows consolidation, complete loss of aeration. Now we see the essential differential between pneumonia and atelectasis. In alveolar syndromes, the common starting point is consolidation. This hepatization of lung tissues appears tissue-like with 2 characteristic signs. air bronchograms appearing as hyperechoic bonds within consolidation, and the shred sign, irregular shredded border with normal lung. But the main distinction is dynamic. In pneumonia, bronchograms are dynamic. They move with respiratory cycles. This has over 90% diagnostic specificity, with frequent associated effusions. In atelectasis, bronchograms are static, with no movement during respiration. The lesion is often voluminous, typically in postoperative contexts. In practice, a real-time dynamic evaluation makes the difference. Now we see pleural effusions. They are frequent in critical care, resulting from numerous causes: pulmonary infection, cardiac failure, trauma, postoperative complications. We have simple effusions, appear anechoic and homogeneous, strongly suggesting transudate, and complex effusions, showing characteristic ultrasound appearance with mobile septations and floating fibrin stands, typically representing exudate. We have the sinusoid sign. This is a pathognomonic for fluid. Its presence confirms liquid nature with good specificity. The mechanism involves the to and fro movement of the lung within the effusion, synchronized with respiration, creating this characteristic curve in the M mode. It's often associated with massive effusion. Along with the positive spine sign posteriorly, visualization of vertebral bodies above the diaphragm, a very sensitive sign for pleural effusion detection. The quantification technique. We use standardized methods practiced in ICU with the patient in the supine position. The principle involves measuring the pleural lung distance in 3 steps. First, diagnose the effusion by placing the probe in the coronal plane at the lung basis. Once fluid is visualized, rotate the probe 90 degrees to the transverse plane and measure the distance. Volume estimation follows with the formula 20 times PLD equals volume. We talk about procedure. For thoracentesis, a common but delicate procedure in the critical care, ultrasound ensures maximum safety. First, identification of the diaphragm, then minimum safety depth of 1.5 centimeter. This is the pleural thickness. Remember, this is a dynamic measurement. Third, avoid high-risk areas verified by systematic scanning. And real-time guidance allows correction of the needle trajectory by orienting the tip. For integrated clinical protocols, we will see in our next session. Thank you all for your attention.